In this chapter, we will be discussing the evaluation and treatment of cervical deformity. To briefly review our objectives, we will provide an overview of the clinical and radiological assessment of cervical spine deformity. We will review major indications for surgical treatment of cervical spine deformity. We will describe the principles for determining surgical approaches and different strategies for approaching different categories of cervical deformity. And we will apply the ideas reviewed in this chapter to a case of cervical spine deformity. Cervical deformity is defined as the loss of upright physiologic alignment of the cervical spine. It can be accompanied by a number of symptoms, which may include pain, neurological deficit, functional limitations such as the loss of horizontal gaze or difficulty maintaining horizontal gaze, mechanical symptoms such as breathing difficulty or swallowing difficulty, mechanical symptoms such as breathing difficulty or dysphagia, and cosmetic abnormalities. It is important to keep in mind that cervical deformity is most commonly caused by iatrogenic injury with prior surgery, disrupting the posterior tension band and resulting in increased compression on the anterior column and progressive kyphosis. With regard to assessing cervical deformity, it is important to assess the symptoms, their chronicity, and their progression. These may include neck pain, horizontal gaze maintenance, neurological abnormalities such as weakness, gait changes, and changes in bowel, bladder, or sexual function. Additionally, it is important to risk stratify by being aware of significant comorbidities. With regard to physical examination, it is important to evaluate both passive and active cervical spine range of motion, as well as strength, reflex, and gait evaluation. After the history and physical examination, radiologic assessment is the next step. CT imaging is important for evaluating bone quality, to evaluate for osseous abnormalities, and in cases of prior surgery, to evaluate the position and quality of previous hardware. MRI is important for evaluation of neural elements and to determine whether compression is occurring. Plain films are important for assessing dynamic abnormalities as well as regional and global spinal balance. There are a number of different radiologic assessment criteria to be aware of, and we will briefly overview these. The measurement of cervical lordosis is conventionally defined as the C2 to C7 Cobb angle. This is measured as the angle between two lines, with one line being parallel to the C2 inferior end plate and the other line being parallel to the C7 inferior end plate. The chin-brow vertical angle is a second measure of cervical deformity that is important to be aware of, and this is measured as an angle between a vertical line and a line drawn between the anterior aspect of the chin and the brow. The cervical sagittal vertical axis is the next common measure to be aware of, and this assesses the regional sagittal alignment of the cervical spine. This is measured as the distance from a line extending from the posterior-inferior corner of the C7 vertebral body to a plumb line dropped from the center of the C2 vertebral body. Now, the T1 slope is the next radiologic assessment measure we will discuss, and this is defined as the angle between a horizontal line and a line parallel to the C1 superior end plate. The T1 slope is important because it is a cervical spine deformity measure that has been found to correlate with global spine alignment parameters. The T1 slope is thought to account for thoracic and lumbar contributions to overall cervical alignment. The T1 slope and cervical lordosis measurements have an important relationship. Independently, they have not been found to be reliable markers of cervical deformity, as they both have wide ranges of values in both symptomatic and asymptomatic individuals. However, there is increasing evidence that it is a relationship between the two values that is a better assessment of deformity. This is because the T1 slope is thought to account for thoracolumbar contributions to cervical alignment, and the cervical lordosis accounts for primary cervical alignment. In addition to assessing for and measuring the degree of cervical deformity, it is important to also assess and screen for global spinal deformities using other well-established measures such as the sagittal vertical axis, pelvic tilt, and the pelvic incidence and lumbar lordosis mismatch. These are not primarily used as measures of cervical deformity, but as mentioned, they can identify the presence of coexisting thoracolumbar deformity that can assist with diagnosis and treatment planning. With regard to indications for surgery, there are a number of possible indications. These may include quality of life measures such as progressive neck pain, loss of horizontal gaze, and functional limitations. The presence of neurological deficit due to cervical deformity is also a common indication, such as with the occurrence of myelopathy or radiculopathy, and cosmetic deformity may also be a relative indication. A proposed treatment algorithm follows. It is important to remember that this is a generalized framework that will need to be individualized to each particular deformity. As mentioned previously, surgical treatment can be indicated with failure of conservative therapy and/or the presence of a neurological deficit. Surgical treatment will depend on the type of cervical deformity. If a patient is found to have a flexible cervical deformity, this can often be treated with either an anterior or posterior approach, depending on individual patient factors and surgeon's preference. A stiff cervical deformity with decreased range of motion without ankylosis can often be treated with an anterior approach for release and interbody cage placement, with or without a posterior approach for stabilization. A fixed cervical deformity will often require multiple approaches. If there is a fixed cervical deformity with anterior fusion, this will usually initially require an anterior approach for osteotomy, followed by posterior stabilization. A fixed cervical deformity with posterior fusion will often first require a posterior approach for facet osteotomy, followed by an anterior approach for release, followed again by a posterior approach for stabilization. If an anterior approach is contraindicated or not feasible, a pedicle subtraction osteotomy may also be a viable alternative. For a fixed cervical deformity with anterior and posterior fusion, a posterior approach for facet osteotomy can be performed initially, followed by an anterior approach for osteotomy, and then a posterior approach again for stabilization. If an anterior approach is precluded for some reason, a PSO may also be a viable alternative. Now we will apply these principles to a clinical case. Here we present a 63-year-old female with a history of remote C4 to 5 non-instrumented ACDF, as well as a later C5 to 7 instrumented ACDF, with several years of progressive neck and shoulder pain, worsening gait, inability to lie flat, and difficulty holding her head upright. On examination, she has full strength and no signs of myelopathy. On her preoperative imaging, her cervical sagittal vertical axis was found to be 5.8 centimeters on upright films, and she was found to have approximately 43 degrees of kyphosis. Her preoperative CT demonstrated a stiff deformity with C3 to 4 facet fusion. Given the patient's progressive cervical deformity with increasingly disabling symptoms, risks and benefits of surgical treatment were discussed with the patient. The patient elected to undergo surgical correction of deformity. The surgical plan was formulated to include the apex of her kyphosis and would begin with an anterior release followed by posterior osteotomy and stabilization. A general overview of the surgical approach follows. The patient underwent front surgery with cervical traction. The anterior stage was performed with assistance by otolaryngology given her prior neck surgeries for exposure. The patient was placed in Gardner-Wells tongs for intraoperative traction. C2 to 3 and C3 to 4 ACDF were performed. Kick-out screws were placed to prevent anterior cage migration. Following this, the patient was then turned posterior, and C2 to T2 posterior spinal fusion with bilateral C3 to 4 facet osteotomies was performed. During this case, intraoperative photos showed prominence of the C3 to 4 cage after correction. A third stage was added in order to revise the C3 to 4 graft with placement of an anterior plate. These stages were all completed in one operative day. The patient's baseline alignment is shown here, followed by the change in alignment intraoperatively once the patient was placed in traction. Further correction of alignment was achieved following the anterior approach and C3 to 4 facet osteotomies. Following placement of rods, further correction of deformity is observed, along with prominence of the C3 to 4 anterior cage. Following the stage 3 revision of the prominent C3 to 4 interbody cage with anterior plating, these images were obtained. The post-operative CT also showed significant correction of alignment compared to the preoperative CT. At 2 years post-operatively, upright films continued to show enduring correction of cervical deformity along with restoration of some cervical lordosis. It is important to keep in mind that there are many potential complications to the surgical correction of cervical deformity. These complications may approach a rate of up to 44%. Complications can include neurological complications such as spinal cord injury or a C5 palsy, dysphagia requiring tube feeding, wound infection or spinal fluid leak, vocal cord injury, pseudoarthrosis, or multiple medical complications. In conclusion, cervical deformity is the loss of physiologic alignment of the cervical spine that can lead to quality of life limitations. Surgical treatment of cervical deformity involves significant preoperative planning. Proper treatment planning also requires assessment of global spine alignment. General treatment principles do exist for approaching cervical deformity, however, each treatment should be tailored to the particular deformity. And importantly, surgical correction of cervical deformity involves significant risk, and the risk-benefit ratio should be fully discussed with every patient.